resistance. Now, although we see the radius of the airway getting smaller from the bronchus down to the terminal bronchioles, we would kind of expect to see more resistance as the radius gets smaller. But in actuality, we don't. Resistance is kept overall low because of the extensive branching that we see of the bronchial tree. So very similar to what we saw with capillaries, because there's so many capillaries and the branching is so extensive, we kind of maintain flow, or we keep resistance low because of that very high branching. And that's what we see here in the lungs as well. So even though the radius gets smaller down in the distal part of the airway, resistance is still low because of that extensive branching. Now, in order to keep resistance low, we must have a pressure gradient that's going to keep air flowing. And so the amount of resistance we typically see is about 1 millimeter of mercury throughout the bronchial tree. So in order to facilitate inspiration and facilitate breathing, we must always have a pressure gradient that's greater than that 1 millimeter of mercury, okay? I'll say that again. So the resistance that we see is usually low, but it's still there, right? 1 millimeter of mercury. And so in order to maintain flow, we must have a gradient that's greater than that 1 millimeter of mercury in order to account for that small amount of resistance that is still present. So if we had a gradient of anything less than 1 millimeter of mercury, that would basically cancel out our pressure gradient and we would not have any flow. So our gradient must always be greater than that small amount of resistance that's present. Okay, now in this graph, we can relate the movement or the function of lungs in high resistance as well as in normal resistance. So on the left here, we're comparing intraalveolar pressure as well as the amount of volume that's being moved. And what we can see is that for a normal healthy lung, we don't need that much of a gradient in order to move this amount of volume. For a lung that has increased resistance, we need twice as much of a gradient in order to move the same amount of volume. Okay, so the resistance is an impediment to flow, just like we saw in the vasculature. So if we have more resistance, we need more of a gradient to move the exact same amount of volume into and out of the lungs. Okay, the lungs have to work twice as hard if there's any sort of resistance or impediments to flow. What are some things that we could be speaking about here with resistance in the airway? Yep. Okay, yep, smoking will give us some excess mucus, and mucus is one of our resistant factors. Anything else? So the diameter, right? The diameter is one of the main factors that influence resistance. So if someone has a narrowed airway or excess mucus, they're going to have a very large pressure gradient to move the same amount of volume. Okay, so there are passive forces that can influence resistance. So basically changes in the transpulmonary pressure, which basically mean that movement of the pleural cavity, as well as tractive forces, so that stickiness of the pleural sac when the chest wall pulls on the pleural sac, which pulls on the lung tissues, that does what to resistance? What does that do to resistance? It's going to decrease resistance, right? So having the chest wall pull on the pleural cavity, pulling on the lung tissues, expanding the lungs decreases resistance, and the reverse is true if we have the chest wall relax, okay? So this tractive force is another thing that can influence resistance. The contractile state of smooth muscle can influence resistance, and we'll talk about the two different states that are important, constriction and dilation. It obviously influences the radius, and we know the radius is really important for resistance, okay? And then the last thing that we want to mention is mucus secretion. So again, this ties into viscosity. If we have more mucus present in our airway, we're going to decrease the amount of flow because we have increased resistance present, and the reverse is true. Less mucus will increase the flow because we decrease resistance. So based upon that understanding, we can then speak about two states of the airway. The bronchial smooth muscles are just like the smooth muscle that lines the arterioles. And so when it contracts, it gets closer together and it closes off the airway. We call this bronchoconstriction. This makes the airway radius smaller. But if it relaxes, it's going to open up that airway and it's going to increase the radius of the bronchioles, right? So we have bronchoconstriction, which is very similar to vasoconstriction, and bronchodilation, again, very similar to vasodilation, right? So changing the size of the airway simply by changing the state of the smooth muscle that's lining that airway. Now, this is under extrinsic and intrinsic factors, again, very similar to what we saw with arterioles. So what kinds of intrinsic things would we be speaking about here that control the size of the airway? Doesn't have to be right. What would you think about? What would you hypothesize? So the tone is going to be influenced, but what factors would influence the tone locally versus extrinsically? Yep, so concentration of gases, right? So carbon dioxide would be one. If we have more carbon dioxide, what do you think, what would you hypothesize? Would you bronchodilate or bronchoconstrict? You'd bronchodilate, right? So if you've got more gases like carbon dioxide, which are indicating higher metabolic activity, that would be cause to bronchodilate to get more oxygen coming in, okay? So it's also under intrinsic and extrinsic controls, just like we saw in the cardiovascular system. So let's look at what those control factors are. So extrinsic control of the bronchial radius includes the autonomic system innervation here. So there's the sympathetic involvement and the parasympathetic involvement. The sympathetic involvement causes relaxation of the smooth muscle or bronchodilation. So this is opposite to what we saw in vessels, isn't it, right? The sympathetics cause vasoconstriction in vessels. In the lungs, the sympathetics cause relaxation or vasodilation. Why do you think that is? Yeah, so you need more oxygen coming in if you've got more metabolites, right? Also because think about the sympathetic function, right? Fight or flight or freeze. If you're running for your life or fleeing from a threat, do you want to bronchodilate or bronchoconstrict? You want to bronchodilate. You want to get more air flowing into your lungs to help get it at oxygen to your vessels, to your muscles, to flee from that threat. So a part of the sympathetic response is to open up the airways, relax that smooth muscle, and bring more oxygen in. And the parasympathetic is going to be the opposite, right? If you're chilling out, you just had Thanksgiving dinner, you don't need a whole lot of oxygen coming in. So you're going to have bronchoconstriction, which is contraction of that smooth muscle, okay? Now let's talk about some of the extrinsic controls. Let's look at some of the hormones and other substances that are involved in the extrinsic control. So we've got epinephrine as one of our hormones, and that's going to bring about the same function as the sympathetic system, but the only difference here is what? What's the difference with epinephrine here? Where is it coming from as a hormone? The adrenal medulla, right? So the difference between epinephrine as a neurotransmitter, as a part of the sympathetic system, and epinephrine as a hormone is simply where it's coming from, okay? So the same response of bronchodilation. So that will relax the smooth muscle and open up the airways or bronchodilate the airway. Let's speak about some local or intrinsic mechanisms here. So histamine is one. Histamine causes bronchoconstriction of the airways. It's released as a part of asthmatic and allergic reactions. This is why people who have allergic reactions typically complain of feeling their throat closing up, because that's what's actually happening. The bronchioles are constricting so much that they're literally closing off the airways, and that's how this can become fatal. That's how an allergic reaction, as simple as it seems, can become fatal. We also see lots of mucus secretion as a part of that allergic or asthmatic attack. What is one mechanism that we use, asthmatics use? Does anyone have asthma here? No? Oh, well. Huh? An EpiPen, yeah. So an EpiPen is what people with asthma typically have on hand, and that is to negate this bronchoconstrictive effect of histamines and the other mediators that are creating that environment. So they stab themselves with that epinephrine dose, and that brings about this type of response, right? Opening up or bronchodilation, and that can help to save their lives, right? And then, as we mentioned earlier, we have carbon dioxide as a local mediator here, and that will bring about bronchodilation. So if you've got excess carbon dioxide, that is an indicator of increased metabolic activity. And so we need to bring more oxygen in to match that demand, okay? All right, any questions? Any questions? Okay. Okay, so let's speak about two pathologic states of airway resistance. So we have increased resistance with asthma, as I was mentioning earlier, as well as COPD, which is chronic obstructive pulmonary disease. Now, we don't know a whole lot about what causes asthma, but we do know that it's a spasm of the smooth muscle that lines the bronchioles. And so it's thought to be caused by hypersensitivity. So these people are usually hypersensitive to allergens like dust and mold, or even things like exercise or stress can induce an asthmatic attack, which is that spasming of that smooth muscle in the bronchioles. And so that makes it really hard to breathe, not only to get air in, but to get air out, right? This is why we call this an obstructive disease. It's obstructing the passageway for flow. And so these people have a hard time getting air to flow in. But when they do get air in, it takes a longer time, and then they have a hard time getting that air out. And so we usually see large chests in these patients over time, as well as expansion of the alveoli, which can disrupt the gradient for flow. In chronic obstructive pulmonary disease, we see a similar mechanism. This is a much more complex disorder. It's usually a chronic form of asthma, so usually 2 years or longer is the criteria to diagnose COPD. It's usually associated with smoking, but a similar phenomenon occurs. There's obstruction or narrowing, as you can see here, of the airway, which prevents airflow in either direction. So hard to get air in and hard to get air out, okay? And we can see here how expanded the lungs are in this, this chronic or this distal image here. This is happening over time, so a long period of time. And then that creates air trapping where there's lots of air stuck in the chest.